at Miami, Lee Kaplan. And Lee Kaplan is orthopedics at Miami. And your fellows, I forgot your names, I'm sorry. Aoud and Adam, great. So you guys got up extra early, came in on the bus. They stayed in Richmond last night, so they came in extra early to do this. So thanks for doing that. Really appreciate it. And we've got some visitors. We have Bernie Bach there in the back, retired to Charlottesville. Andy Cosgarea from Johns Hopkins, and Matt Provencher from Vail. Yeah. So we appreciate you guys coming very much. And so there's a variety of people. Winston Gwathmey is my partner. He's going to run the AV here.
I'm the IT guy.
Yeah, and I think the fellows are going to take control here in a second.
So we have a bunch of our fellow alumni also on the call.
Oh yeah.
So I don't know if you guys see the screen up there, but we have Garvin Smith, University of Miami guy. We have Bobby Brownings, our next coming fellow, Robbie Schutterbeck, Carol Burris, Courtney Quinn, Josh Nelson, and others. So let's see.
Chris Bankhead, yeah.
Chris Bankhead.
Wow.
Karen Tree, big squad.
Wow, that is really neat. So, New Mexico, wow, everywhere.
Thumbs up.
That's it. Great. Thanks for organizing that, Winston.
Yeah. We get started?
Yeah, I was going to say one other thing. So we'll kind of alternate some cases. We'll present the first one and try to get through as many as we can because we have, I think, some great discussion. Feel comfortable to get up, get food as you like. So there's several residents here that are going into sports and applying. So if that's you, raise your hand so you guys can be seen. We have
might be a first round draft.
So 4 from our program are applying this year. They're all stellar. Absolutely stellar. You guys should meet them while you're here. All right.
All right. Thanks, Dr. Diduch. Good morning, everybody. I'll start us off today with a case from Dr. Miller's service. This is a 13-year-old female with a history of a prior left knee ACL reconstruction. In September of 2021, she was playing soccer. She was flipped by a goalie and she landed awkwardly with a pivot shift to her left knee. That was her initial ACL rupture. And in October of 2021, she underwent a primary ACL reconstruction with a BTB autograft and metal interference screw fixation. She rehabbed successfully, returned to play, and exactly 1 year later, in mid-September, she was playing soccer when she took a hit from behind. She had a hyperextended knee and twisting valgus force applied. She had immediate pain, swelling of the knee. Returned to see us. BMI 22, healthy gal, otherwise no surgical history. On physical examination, she had already regained her range of motion by the time she came to see us. She had a 2B Lockman and a positive pivot shift. Here's her preoperative imaging. So you can see the interference screw fixation from the previous ACL reconstruction. You'll notice that we obtained AP lateral and then a full length lateral of the tibia. So in assessing her, we felt that our tunnel position was appropriate from the initial surgery, and we were looking for other potential risk factors that could be contributing to her ACL failure. We measured her posterior tibial slope to be nearly 15 degrees. And so you can see that here on this zoomed in image. Preoperative MRI was obtained to further evaluate tunnel position, evaluate for any osteolysis. Didn't appear that there was any significant osteolysis on X-ray, and on MRI that was again reconfirmed. No concomitant meniscal or cartilage pathology was identified either. And so we felt like our tunnel positions were appropriate, and without significant osteolysis, we felt that we'd be able to do this procedure in one stage. So this is a gal with a left knee ACL rupture in the setting of excessive posterior tibial slope. And so the plan for her was an anterior tibial closing wedge osteotomy and a revision ACL reconstruction with quad and bone block and removal of our previous ACL. So there's a lot of preoperative planning into this case, and I'll briefly take us through it. So as I mentioned, we felt our tunnel positions appropriate. We plan to reuse those. And we plan to reduce her posterior tibial slope 15 degrees to around 5 degrees. This is a paper out of this institution that summarizes kind of the millimeter wedge height degree of correction for either a supraphysical or transcubital technique. And if you're going above the supraphysical, then you can use a 1-to-1 ratio, 1 millimeter wedge height for every degree of intended correction, whereas going through the supraphysical, 1 millimeter, 1 degree correction. This is kind of a different paper which shows some of the more complex math behind that summary that I just provided. And so for this patient, the plan was to reduce her by about 9 to 10 degrees. There's a really nice paper in AOS Global Research and Reviews. And this is essentially exactly how the end of the plans for Dr. Miller and my co-fellow. So here's a lateral of the knee. You can see the purple line represents a perpendicular to the tibial slope, so that would be neutral tibial slope. X represents the amount of excessive posterior tibial slope in our patient. That was about 15 degrees, 14.5 degrees. Z is the amount of millimeters of the wedge that will be resected. And then Y represents the angle of correction that you're hoping to achieve. And so this is how Dr. Miller rapidly planned this wedge to be about 9.5 centimeters. So intraoperatively, you can see that we've skeletonized the patellar tendon here. So interestingly, as I mentioned, she had a previous BTB harvest. And so you can see that after elevating, preserving the peritoneum, that had filled in rather nicely. Then proceeded to place 2 pins, as shown here, and measure 9 millimeters up for our wedge resection, and then place 2 pins here. So the first 2 are placed perpendicular or parallel to the joint surface. The second 2 are placed perpendicular to the axis of the tibia. And this creates your cutting guides for your osteotomy. And so we were careful to measure from the top of this pin to the top of the superior pin, since that we'd be using them as guides for our saw. So our saw would be resting on the top of this. And then you can see here in this next image, moving forward with first section, this video will play for us. So you can see the thyroid retractor protecting the patellar tendon anteriorly. Like my co-fellow, I'm not sure coming with the saw across the anterior cortex here and completing that cut. We previously skeletonized around the back of the tibia so that we could place retractors around the back for the rest of the cut. Okay, keep flying forward again, but you can see here as we come through with the saw, and then this is how the osteosome moving to resect that wedge of bone.
Good one.
So as that wedge comes out, you're able to pull out a significant amount. However, this step is important. So this is a curette that we placed into the osteotomy to help remove the cancellous bone further posterior than where we took our saw blade and removed our wedge to ensure that we'd be able to achieve the correction that we planned. So after curetting that out, you can see what that X-ray intraoperative fluoro looks like when that wedge shaped area has been properly prepared. And then this is a K-wire, which is used to drill postage stamp perforations in the posterior cortex to assist with completion of the closing wedge. So here, hinging on that posterior cortex that we just perforated, the ability to close down that space. Here's intraoperative fluoro showing what that looks like. And then this is part of our staples. So there was one place on medial and lateral to the patellar tendon anteriorly, and then a third staple placed laterally to help prevent varus collapse, which you can see here on these X-rays. And then additionally, as I mentioned, this was also a quad tendon revision ACL. And so this image on the left demonstrates the ruptured graft. The image in the center demonstrates the empty wall and the previous metal interference screw. That's removal of the previous metal interference screw there. This is an intraoperative fluoro with our pins at our tunnel positions for our revision ACL. We backfilled the previous defect with the bone down, and we're able to place a pin and drill for our socket in the appropriate position. This is our fixation here. And so final films, this here is your quad tendon, that's where the bone block is. Here's our fixation for our revision ACL, and then our staples for the osteotomy closure, and then backup fixation on the tibia. This is a little image of the tibial infix device, sheath and infix device, which Dr. Miller refers for his tibial fixation. Those are our final films.
Great case.
Comments?
What consideration do you have specifically in terms of placing those staples to make sure that you have the room on to pass the map?
Yeah,
Yeah, so those are compression staples, and the idea is that those are made out of nitinol. And this particular brand, you can breathe tension if you need to, which is nice because it can all do that. But yeah, we're trying to keep that as far as we can central. So we have room for our table, a tunnel to the side of that. So we got lucky that we were able to get by them, but it was close.
And then the other question I have is, Mark, I remember you coming to Pittsburgh probably around 2000, you and Craig Bennett doing your PCL reconstruction inlay, and everybody else in the room was scared, and you were pretty comfortable in the back of the knee. So I didn't see any retractors in the back. You're just saying to yourself, we're really just perforating the back, so we don't have to get around back.
Right, so when you're perforating that, and so the younger folks don't understand what postage stamps means because you just peel them off your when you buy them at the post office, but there's little holes on the side there, and the idea is you make those little holes, and you don't go deep when you do it, you just make it through the cortex. Enough of those holes, and it'll close there. It works good for all osteotomies, really. It'll close without cracking the back, and so yeah, we felt pretty safe with that. The other thing that you can see that fixation there. I like to take the quadriceps graft, and I do this for ACLs also, and you keep a bone block, but then divide the other ends into 4, which turns out to be pretty easy because it's a quadriceps. Anyway, so then we divide it into 4 components, put a suture on each end, and then I call that the quadrupus. It's like octopus, and then that way you can put the screw in the center with the screw and sheath. And we showed with the PCL, biomechanically, that's the strongest fixation you can get, is to have a really good fixation. It smashes it to the side and provides excellent fixation.
So this was your,
It was a beautiful case. So the wedge that you took out was, did you say 15 degrees?
So 15 degrees was or 14.5 degrees was the strategical slope at the beginning of the case. We had planned about a 9-degree correction to get down to 5 degrees. So the wedge was 9 millimeters.
So it looked like there was a lot of hyperextension postoperatively, or at least intraoperatively, closing the wedge down. And I wonder how do patients tolerate? So now she's got more hyperextension than she had preoperatively. How do patients tolerate that?
Yeah, there's no question about it. I mean, it's crazy repromodeling. The first couple times you do it, you go, you gotta be kidding me. There's no way. But it corrects itself. It somehow just resolves over time. I don't understand why, but thank goodness.
so when you see these over time,
Yeah,
when you examine them at 6
yeah.
months or a year, they
Yeah.
last.
I bet even, you saw them like last week, I bet they're even better.
Yeah.
Yeah,
Yeah,
it's amazing.
I agree with that. It's kind of interesting how they lose their
Right.
hyperextension. I bet she even had 10 degrees to start with minimum, just
Probably.
based on her slope to
Right.
start, on exam. But it's amazing how that corrects down, because it shouldn't biomechanically, but for some reason, I don't know why it is. Those staples are pretty cool, adapted from our foot colleagues doing bunions to be able to, the night and all compression is pretty cool. It's nice to be able to do this all in one stage. These are ones that I'm consistently humbled about, but with the, I was just talking to Vidal about this the other day. We were looking at some differential slopes on medial lateral plateaus, and I'm consistently humbled by the slope of these, especially when we're getting the hip to ankle CT scan and throwing it in body CAT, and then doing the slope correcting osteotomy. It's pretty powerful, some of these biplanar osteotomies and jigs and some of the other things you have now. This is the way we're always taught to do it, the way we did it, the way we've done it for a long time. But the body CAT has helped change the game quite a bit on this, in terms of, we probably know too much at this point, in terms of all the angles, all the numbers, all the things about the knee, but this is the way we've done it very well. The other thing, we published a paper back in the day looking at single strand versus 2 and 4 strand constructs. That's 100. We looked at, it's almost a 2 to 3x difference when you actually split the strands up. And that concerns me a little bit about a single strand, because you look at it, you put a big strand of tissue in there with an interference screw. It's just touching only so many threads of it, and so that's all the classic spread out. And we've lost this technique along the way with the 4-stranded devices, things like Intrafix and other things from the Pew that we've used to use forever. The plastic sheath, that sheath was designed in the gold standard for soft tissue fixation. Great case, really nice. I bet she's going to do really well. It's amazing. My last question is, we have this debate a lot in Vail, is double bone harvest off the patella.
So I haven't had trouble with that, thank goodness. But I make a point when I do a patella tendon graft is to fill in the defect with bone. When we drill, we get the drill part, and it's really nice bone, and it can pack in there, and that fills in very nicely. I think it does fine. And then the tendon, interestingly, how it filled back in, and I always leave that gap and just close the peritoneum on, because I'm concerned if you close that, then you may decrease the width of the patella tendon. So I always leave it open. This is anecdotal, one case, but looks like it really reconstituted nicely.
Actually really did, because I do the opposite,
Yeah.
because I always worry that you're leaving.
What do you tell them in terms of post-op. So now you have a 13-year-old young woman. What do you tell her and her parents in terms of reasonable, now that you've had this revision and you've got this going?
Yeah, so, well, first of all, we protect them with crutches for at least 6 or 8 weeks if we see some, some sign that it's healing in. But as far as long-term, I think that she has a good chance of doing just as well as almost a primary. Revision is never as good as primary, but if there's a reason that they failed like this, then I think maybe they have a good shot at returning to regular activities.
We have found these slope corrections very powerful.
Yeah.
And I think I 100% agree with that. I don't think you don't do it and recognize this 13, 14, 15, however you measure and slice it up. It's a problem for her down the road. She's going to need another one, but this gives her a fighting chance. And that's been our experience.
This is what they do for dogs. When a dog has an ACL, it's what they do.
Paid for 2 of them.
Hey, Mark, can I ask you a question?
Please,
This is Todd Battaglia. How you doing?
good. Thanks for joining us.
Yeah, thanks for having it. So, this girl is probably as prime for a failure as they come initially. Female, decent slope, young athlete. Would you ever see a slope that you would address in a primary procedure? And if not, would you do anything else for her if you recognize that? Would you add something extra articular or anything beyond just a standard ACL?
My partners joke with me, but I have done this in a primary ACL. And so if it's 15 degrees, I'd strongly consider that. And a lot, some people critique you and they go, well, I wait till the second revision. Really? You know what you put these kids through when you have 2 revisions? So I'm pretty aggressive about it. Now, I've never done it without, prophylactically, but I heard one time Ned did that, like with no ACL tear.
So it's important for the residents and fellows to understand that I have published 25, 30, and now 35-year personal experience with revisions, reoperations, allografts, et cetera. And a female under the age of 15, in my personal experience, had the highest failure rate of 7% on the surgical side and nearly 20% on the contralateral side. So you really have to educate these parents that this is an individual that's at high risk for failure compared to the average. Once you get beyond 25, the failure rates are really, really low, whether you use a BTB autograft or a BTB allograft. But it's a group under 25.
That's a great point. And Todd, back to your question, we do use extra articular augmentation. We prefer the modified Lemaire for most revisions. This one I felt like I didn't need it because it was the slope was the major issue. And so, but we do LETs quite often.
The only other comment I might have, I'm sure you guys checked it, was that, just hip to ankle. A lot of these are biplanar. You have a valgus active female is a big issue. Sometimes they're at, 55, 60%. She'd probably be protected, so you get away with it because anything beyond 50 to 70 has been shown to be protective in terms of percentile weight bearing axis. But we've been fooled, even though they might be valgus active female with glutes and other problems. Their bony alignment is actually varus. So I've been fooled a few times.
Well, the other thing is we've had a couple of fall into varus collapse. We have a paper we recently published with the guys from New Mexico where we have 3 cases of fall into varus collapse. They weren't before, but I think that's why I have the extra staple there because I'm concerned about that bone on that lateral side.
Is anybody doing any different fixation for the staples?
Yeah.
This used to be, this is great for me. I have migrated 100% over the last 2.5, 3 years to body cap, basically. So it's a custom 3D printed stainless steel plate specific for the patient. But it does take 4+ weeks to get out of Canada to get it over the border. Get it finished. kind of migrated that. With that though, it's not perfect because you can fool yourself. It's really kind of a whole anatomy of the tibia. They're very nice for moving your body. And get very close to the joint line. So you have to be a little bit careful.
So has anybody gone to the inferior below the tubercle, that's intriguing. I think that may be a good option too. I'm concerned about the diaphyseal bone, though, may not heal as well, but that way you can avoid the tubercle also and go below it.
You look at our CD ratio here on the left, it's probably a little bit different. I worry about that. I've always gone super tubular. But I had a partner back in San Diego in the Navy that was always infratubercle. His insult fellow way back in the day, 25 years. He did inferior tubercle osteotomies. It was interesting. They were much more, I think the fixation's better now, but there were way more complications with it. Because the bony area, the vortex, the rotational issues where they're very easy to get in trouble. But
I mean, basically create a dreaded black line iatrogenically.
yeah, I've always.
Marvin, do you have a question?
Yes. Good morning, everyone. Marvin Smith, Memorial Sports Medicine. Awesome case. I wanted to ask what the range of motion restrictions are post-operatively, and also have you noticed any significant post-operative stiffness compared to just primary ACLs? Thank you.
Yeah, Marvin, thanks for the comment. Welcome. Good to hear from you. So the bottom line is I do not restrict this motion unless I do a meniscus repair. I treat this just like any other ACL. I give them full motion. And in fact, I cringe when sometimes they come back in locked in a brace. So we have big signs on our braces now to unlock it after the block wears off. But so I've not restricted the motion. I don't see any reason to.
Awesome case. We should probably move to another case. I think this highlights, there's a lot of questions still to answer, right? LET, slope, etc. Are you guys pretty aggressive with LETs now?
I don't know if we're pretty aggressive, but much more so than.
Yeah, we are.
Past. I went over to Brussels and saw, they're doing LETs, some literature we were looking at in high-level soccer players, and they're doing LETs and actually hamstrings on almost everybody. And their results with good alignment seem very strong, but there's definitively a case for it, I would say, and to at least consider it in anybody that's failed a primary.
That's kind of where we are. Yeah.
I think first of all, Alan Keck is important again for the rest of the fellows to understand. Alan Keck's a paper dealt with it exclusively hamstrings, and you don't have to do it with patellar tendons.
Well, we don't know that, Bernie. That's why we have a second
Well, you have a
study.
second arm, but I can tell you with 30 years of it, when you have a personal revision rate of 1.5%, I don't know how I can make that better with an LAT, and I think I can make patients a lot worse with an LAT.
So Bernie, with this situation though, when you have this situation and you go back, would your graft choice not been a quad, it would have been condylar bone patella bone?
And
What would
maybe
your
well, the problem is a 13-year-old. And, I think this is a very difficult case. It's impacted by lots of different things. I'm not certain what I would have recommended. I probably would be giving this a lot of thought, but I doubt that I would be using a BTB allograft, and probably the quad tendon would be a reasonable choice.
Yeah, the double, it's interesting. I think we started looking at our double hits to the knee. I think the double hits with a hammy and BTB is worse than the patella BTB. I think there's I think the hamstring hit on a young female is underestimated, especially the valgus active female. I really like your graft choice here. Depending on her height, her size, and clearly, I mean, she must have been 11.5, 12 when the first one was done.
Right.
Right. I mean, that's with the BTB, it's very young. Yeah, I agree.
The other point I wanted to make about the lateral extraarticular is everyone needs to go back and look at Steve O'Brien's paper. I think it was published in around 1990, and there was the HSS experience looking at an ACL reconstruction with and without extraarticular. There was no difference in stability. There was a higher reoperation rate, more pain with the lateral extraarticular. And basically I did it for about 1.5 years in practice, and then with that data, abandoned it.
It was a long time ago.
What's that?
It was a long time ago.
Oh, Jesus, you know.
It's like everything in orthopedics, so we kind of go cyclic, you know, we do this, it's a stupid idea, quit doing it, then you go back again, let's do it again, you know?
Yeah,
It's
yeah.
everything cyclic.
Pendulum swings way over.
Yeah.
It's overused and it kind of comes back and you kind of figure out what the indications really are.
Right.
You weren't teaching 18, 20 years ago.
What? Yes. No.
I would on the first one, University of Miami. I was going to present some cases that I was involved with since starting my fellowship. So first of all, present the first case here. Just keep an eye on this gentleman right here. Essentially, 90-year-old linebacker, right in pain after attacking at the end of his helmet. And to the pain and saw the inability to weight bear, significant on pain. Start with water, normal position here. Initially, when images is seen, obviously the range of motion was a little bit limited, also with pain, and infusion, possibly long-term, and posterior charge test, and had some laxity with the body stress. He was stable to bear stress. I was a vascular impact. These are raised X-rays, which are most remarkable. That's disclosed. These are MRI, which I'm run through that here.
Go a little more slowly. Yeah, just the opportunity.
Can you show that coronal again? Could you breeze by the popliteus tendon pretty quickly?
I will that.
Sorry.
No.
Good he asked.
Just look at that picture here. So essentially, I'm fully CL tear. I tear his PCL, approximately at version. Also had an NCL and MPF and tear optic femoral that's on the side. He also had a meniscus tear. So consideration of time, so there's always timing. I did have some swelling, we just range of motion. So usually we give them a little bit of time to rest and improve their swelling, improve their range of motion. There's also a risk of causing too much stiffness if they go into surgery quickly. When they serve the contraction with a BTP autograft. PCL was considering repair versus reconstruction because it was a proximal avulsion. If the quality of the tissue was still good and retracted, we would consider a repair. And also given the injury on the medial side and the avulsion, we would consider MCL repair as well as MPFL repair versus hospital reconstruction. It's just a systematic review here, which essentially reviewed the multi-ligamentous injury. All this is more in the general population. While this is this is more athlete that where they get much more drop in post-operative care to the trainers. But essentially here is to show that if you go to surgery too acutely, you tend to get residual anterior instability as well as some loss of flexion. And also we have post-operatively, it's also to keep them moving and didn't immobilize and didn't run for too long. This is just a couple of papers about repair of the posterior tissue, which essentially it's a viable option if it's proximal avulsion and the quality of the tissue is good. It's also advantageous to ligament setting where so you know you need to use less auto or allograft. This is another study essentially showing that for fellow avulsions, although it's not for softness and multi-ligament injury, but just showing that repair and allograft and autograft, you get a similar outcomes and similar strength. So essentially what was done, we did a partial mastectomy of this injury. When we went in, the quality of the tissue of the PCL was very good. We essentially elected to do a repair at the foot with an anchor. We did an ACL reconstruction with the autograft with interference screw fixation. We then opened up the medial side where we were able to find the MCL and MPFL avulsion injuries of the femur, and we were able to repair it back to the anterior anatomic position. The MCL repair was augmented with internal brace. These are just pictures. This here picture of the PCL, ACL reconstruction here. These are just pictures of this was the MCL, which has robust tissue, and the MPFL. So he's now about 10 days of surgery, pain-free. We actually had more issues with the anesthesia and after the meeting. He's definitely swelling and now doing well. Our plan is essentially to work on his range of motion once he's better, and you know he's essentially done for a season. So we're gonna rehab him more slowly as for return for next season. I was gonna this is the second case of the presentation. So I was gonna say that he had a similar rehab in the last patient. That's what it is. Stacks here.
It was kind of interesting, you know, the degree of injury on exam, because our facility is kind of similar to this, but the football practice field is closer to my office than is the athletic training room. The football field's right downstairs. And so we're a little spoiled in that fashion. So they brought him over, I was able to evaluate him, and we had an MRI all, you know, within 90 minutes. My biggest concern, and it's interesting because it's a medial side injury, was how comfortable he was. He was neurovascularly intact, and you know, some of these kids are pain one way or the other, but I was actually a little concerned that he wasn't more uncomfortable. In my hands, and some of it was a while ago, out of Vail and other places, talking about ACL reconstruction early versus waiting. And with this situation, I was expecting to have a ton of swelling. And you know, I'm still a little old school in terms of the capsule and how that all works. But just for the residents and fellows, obviously you're worried about tissue that can cause any kind of neurovascular issue if you put too much fluid into it. So there was something that I once probably read somebody in the room did, or at Herodicus was mentioned. But I just put the scope in, turned the fluid on, put the person with the least experience, so RPGY2, I said, you're in charge of neurovascular. Every 20 to 30 minutes, just check his compartments by feel. But as soon as you put in the fluid, when you have this injury, it's going to pouch on the medial side proximally. I just made a small incision, the fluid runs out, you put the bag around, it's no problem seeing, and you kind of go from there. And then the only other thing that wasn't necessarily articulated is I want to make sure that I do a good job on the medial, and on the next one, you'll see the lateral side of the knee prior to locking down the central pivots. It's kind of a back and forth. So distally, I don't put in the fixation yet, past the graft. And this was really an anatomy lesson once we opened it up. I would say that the biggest thing we did use fluoro, looked at the tubercle, looked at the insertion site of the MPFL, et cetera, and came together. The one thing, unfortunately, we didn't have a picture of was the entire posterior part of the PCL was still intact. It was really that anterior sleeve had come off. I've been involved with it just for full disclosure, but I do like that suture anchor in particular because I pass suture using the shoulder set, just using scorpion and so forth in a locking fashion. And then once you put that suture in, if you use the knotless piece, you can then grab that knotless end and arm and put that through to reef yourself up. And that's just something I found useful. And we did that on the medial side. Remember that the medial proximal part of the MCL is actually, you think about how wide it is distally, it's not as wide proximally. And so you really want to make sure that you put the fixation exactly where you need it from the jump. We looked at this, maybe even when Marvin was here. Marvin, it's great to have you on. Marvin was our resident and really had the honor to come up here to do his fellowship and love that he's still in our area. But when you do these particular cases, one of the things that we saw, and we looked at it with our primary care people at the time, was younger African-American athletes have an incredible amount of coagulation ability. And so early on, we had a DVT after just a meniscectomy. So we've looked at that always. So we go right after them, which we would with anybody with this, but in terms of all the DVT prophylaxis as early as possible, even though they may have some bleeding and swelling from that, we're cautious. And then Ehud said something that, everybody in this room has the ability to do that most patients on the outside don't, which is we have them, they're in the chamber for hours getting rid of their swelling every day. So we're a little fortunate in that regard, but any critiques, we're happy to hear, honestly.
So if I may, that's an excellent case. And what you mentioned is what we call an egress incision. And so we make that in the middle part of it, and water just goes on the floor, and anesthesia's not happy, but we aren't. So they can just go buy some boots. As far as the PCL primary repair goes, I think it's important to also look at the quality of the PCL that you're going to try to fix. So it's important, I think, to make a posterior medial portal and visualize that PCL, make sure it's not intrasubstance damage to it. The other thing we've learned is that and this is in the literature, there's a length that is critical length that you can repair, and it needs to be about 41 millimeters to make sure that you can still repair it primarily. So it's quality of tissue and length as well as where it is.
I almost felt, and this is maybe a poor analogy, I just felt like on this case, I was thinking a lot about, we have a lot of substance abuse around weightlifting in South Florida. And so we'll get these partial biceps tears in the elbow. And I almost felt like that because there was a lot of good tissue posteriorly. So it helped me on those two. And then I didn't go posterior medially, but you can take a 70-degree scope and go, since you're taking out the ACL anyway, and get a pretty good visualization of how the PCL goes around a little laterals. Those are really good points.
Well, what was the grade on exam of the PCL?
He actually had an endpoint, but he was soft, like a 1, because he wasn't a
So
true.
this patient had been, say, 40 and recreational athlete, but had this degree of injury. Would you approach it the same way? You think? I think this is great for an athlete.
I mean, probably because of hubris, I probably would have said I'm in there anyway, so I'm going to fix the PCL, but I can't give you a great reason that would make a clinical difference.
Would you fix the MCL? Would you embrace rehab, potentially let the MCL tighten up, and then
your point's a really good one. Yes, you could have done that. You would have had to probably say to yourself, when I go back, if it shortens or if the tissue quality is not as good, further down, I may have to do a reconstruction, not a repair. So I still think this is the bet. I almost looked at this as really, this wasn't a typical proximal MCL, right? And where you're saying to yourself, let this heal and then I'll do the ACL. I felt like once he has the avulsion of the MPFL and the entire capsule, it's just a higher degree of injury. And then, quite frankly, Bernie, there's a complete bias that I think cannot be underestimated when you have video of the injury.
Yeah.
And so when you have that video of the injury and I know we can all look at an MRI and kind of think about it, but wow, you got his knee blown out. It does make me think, let me fix more. But it's a very good point. And in the trauma center, which we have, we'll see injuries like this with concomitant other bodily injuries that we can't touch, and they wind up doing very well and coming in and basically getting an ACL.
So the point, I think, again, the point is, there are some patients who have pseudo knee dislocations that you don't have to fix everything. And we were a level 1, we were not a level 1 trauma center. We were a level 7 trauma center. And you get these patients that had a radiographic documentation of a knee dislocation. And they get sent in, and by the time they send in, they've been put in a split or a cast, and you're seeing them for the first time in 3 or 4 weeks. And they've stiffened up enough that you don't know what you should fix. And then remember, the PCL has the potential to heal. And some of these patients that would be sent in with bicruciate injured knees, they get in, and by that time, I can't make a grade 1 PCL better surgically by the time they stretch out post-op. So the PCLs I'd fix were the higher grade ones, but totally different than a level 1 trauma center, and totally different than an athletic injury. Or patients that are walking down the street and they get hit by a car and they've got either a medial or lateral side blowout. I would really try and prioritize it if they had a lateral side blowout, acutely doing the posterolateral corner, and then sometimes coming back and staging.
So this MCL had joint fluid tracking, all the events. That's good. That's good.
Yeah.
That's the important thing for the trainees to recognize. Was a good MRI, David. Yeah, that's good.
This case is super interesting. Your video thing, the video analysis, the amount of energy that goes into this is key. This is really kind of this valgus blow, so you're not surprised at all by the medial. In football, I'm consistently not surprised anymore by the amount of MCL and MPFL concomitant injuries. They're anywhere, the posterior oblique is maybe 5 millimeters, the attachment, the superficial is a little bit further away to the MPFL attachment, but these often go together, and they'll have patella partial subluxation plus an MCL, and this is a really bad medial sided injury. And yeah, I like the way you treat it. Any way you can get their own tissue to try to heal, especially with PCL. And reality is the NFL Combine, if you're looking at those PCLs and you had politely ignored that PCL and not did anything, they would probably be just fine. And there's at least 10, 15, 20% of, depending on the year, of some PCL partial insufficiency based on position, running back, wide out, what have you.
I do think, though, that combination of a PCL, you know that you're going to have some patella instability together, since you know the long-term implications of PCL injury. That's just kind of something.
And that, by the way, yeah, that's amazing too, that the medial and patellofemoral degeneration kicks in much more rapidly than I thought. Because we know the injury dates get to the NFL Combine, and those are only real true issue, and it's like 2 years after that significant medial compartment and patellofemoral issue.
I agree with you. That's and I suspect this was more than grade 1. In order to really quantify it, I advocate for stress radiographs. And so we have a TLOS machine we use routinely that helps us to do that. And so we showed in the lab that if you have more than 10 or 12 millimeters of posterior displacement, then it may be a combined injury, as this was, and often it's posterior lateral corner with PCL.
Lee, did you use a tourniquet?
I did use a tourniquet. I don't routinely use a tourniquet unless I do when I grab quad tendon, but on a patella bone, I usually don't. But we put it up initially, and then I took it down to do the needle side.
Alyssa, you had a question?
From a community setting, so we cover high school football, and you see this in a high school football game. And so on the sidelines, you take them off, you're like, okay, I'm concerned for a multi-leg knee injury or knee dislocation. Get pulses, but theoretically, if we see somebody with this injury in the emergency department, we say get ABIs, if you're concerned about ABIs, get a CTA. Where, would I send this patient to the emergency department? I guess every once in a while for some of these high school kids, you get a little nervous to send them home.
So we, once again, totally biased because of the training room and the locale. So I don't know how many times you checked them that day, but we checked them multiple times. We did have that discussion. We're extremely sensitive to that. Our institution, about 9 years ago, had a high school football player with no pain come in with a knee dislocation, relocated, put on the floor. That wasn't done and wound up with an amputation. So we're as bad a situation as possible in all respect. Actually, never seen, ortho had gotten a phone call, but actually they did it in the trauma center. And so it changed policy and everything else, but everybody's very sensitive to that. I don't think you ever go wrong doing that. I mean, I don't know if everybody else.
We had a similar thing. You remember the kid?
Yeah.
This was probably about 7 or 8 years ago, a high school kid. It was actually not local. Where was he?
Woodbury.
Yeah, who had the same thing, unrecognized, obviously interval flap or whatever, but ended up with an amputation. And he was like a big time recruit, et cetera.
So the answer is yes.
Yes.
Send them to the ER. Admit them for serial ABIs overnight.
If you think it's a knee dislocation type of injury, then yeah, you should definitely have that looked at.
The other thing is that Ed Voigt has had a patient with pulses and everything fine, but had an intimal lesion and put the tourniquet up and got into trouble with that. So you have to keep that in the back of your mind.
Yeah, that's it. I've been burned by an intimal tear and missed it. Typically, they're fine. They show up 2-3 weeks to your clinic. They're talking about reconstruction, multi-lig. I have a low threshold to get a CTA. If they've had a true multi-lig, if you got video, if you've got the energy that goes into the injury, it's a CTA. They can do a pretty quick study. It's about 2 minutes of a scanner with a squirt. And if you get in trouble, we've had 2 instances with intimal bleeds unrecognized.
The other thing is I stopped using a tourniquet for everything. Osteotomies, PCLs, multi-legs, ACLs in 1991. And I think the patients they just seem to be so much more comfortable. I don't know if the data doesn't support that. But boy, you talk to our fellows and ask them how do my patients look compared to the other partners, the amount of swelling, the comfort, level of comfort seems to be different.
Yeah, the other thing I have been thoughtful about, I was once asked to help one of our colleagues. There was a situation with a lacrosse player in the Northeast who had kind of had multi-lig, a really subtle kind of perineal nerve. It's just decreased a little bit, very well documented. But after putting the tourniquet on, she was out. And it wound up slowly coming back, but it was a big deal. And so your point's really well taken. And
How long did it take to come back?
6-9 months.
Is it that long? Yeah.
There was some documentation for the tourniquet specifically, because you put the tourniquet on.
When they talked to neurosurgery, they said it's almost like a little bit of a double hit, double
vascular. Okay. But you think it was that versus whatever was done during the procedure to stabilize it?
Yeah, I didn't have that. I was just trying to help them get to the right decision, which I'm sure you guys all have as well.
It's a good question.
All right, shift gears here. Yeah, we're gonna shift gears. We've had 2 interesting knee cases. We're gonna show the case here. I'm Greg Goodlaw. I'm the sports fellows at UVA. So for this case, is a 21-year-old right-hand dominant lacrosse player here at the University of Virginia. He reported an injury 2 weeks prior while playing for the Canadian national team. He described an injury for which he fell on a forward flex, deducted his shoulder during a championship game. He was taken to the sideline for posterior shoulder pain, and based on his description, it sounds like there was an attempted reduction maneuver. He was actually able to return to play that game. It was a championship game, so it was obviously very important. Since that injury, he's been unable to fully participate in sport due to persistent posterior shoulder pain, specifically with lacrosse type activity.
It should be noted that the US beat the Canadians, despite his return.
That is correct.
Yeah, we went easy.
So for his physical exam in clinic, it was overall fairly benign. He did have some concerning findings for posterior labral pathology. So the decision was made to proceed with advanced imaging. Here were his radiographs in clinic. They were remarkable. So here are a few still shots from his MRI imaging. On the left, the axial cut there shows anterior humeral head edema, which is consistent with a posterior instability event. The next two images show that there is extravasation down into the axillary pouch, down the humeral shaft, as well as extravasation into the posterior musculature, concerning for an avulsion type glenohumeral injury. So here are some axial cuts of the MRI, again, redemonstrating the anterior humeral head edema, and then you can see the extravasation going into the posterior musculature of the cuff. Here's some coronal images as well. There's no other pathology noted on these MRIs. So he's 2 weeks out from injury, trying to decide whether or not this is someone who would need a surgery or could be treated non-operatively. We felt that we would best, at this time too, is the fall, his season comes up in the spring. We felt like this was a good opportunity to address this surgically. So the plan was to do a left shoulder diagnostic arthroscopy with reverse haggle repair. So here's a intraoperative picture. This is a cardinal sign of a reverse haggle. This shows a retracted posterior capsule with exposed infraspinatus muscle belly. And then I'm going to go through the video here. So we use the two portal technique. This is us viewing from the anterior portal looking posteriorly. You can see the capsule retraction there. We're working through the capsular defect. You can see the rent in the capsule from where we performed our diagnostic arthroscopy. Here we're looking for any other pathology, looking at the posterior labrum, looking for any chondral defects. The superior labrum looked intact as well. Now we're viewing from the posterior portal through the capsular defect. You can see the capsular injury here. This is with a 30-degree scope. We then switched to a 70-degree scope. We felt like we could visualize more inferiorly using the 70-degree scope. We're placing a 1.8 millimeter knotless anchor here. Here's looking through the posterior portal, once again, evaluating our anchor placement. We then use the suture passer device, 45-degree, in order to bite through the capsule. It was very difficult to get that angle inferiorly, so we ended up placing a traction stitch to help elevate the capsule, and then went back in with another 45-degree angle device. So here we're passing the repair stitch. You can see the traction stitch up there superiorly here, and the repair stitch is passed, and then we do the same thing just superior to that and pass the shuttle stitches as well. We did not make another portal posteriorly. Again, this is all through just that capsular defect. So here we're using the device to pass the shuttle sutures. Once the shuttle sutures are passed, we then shuttle the repair stitch to reduce the inferior aspect of the posterior inferior glenohumeral ligament. One of the things with using the two portal technique, you just have to be careful for tangling the suture. So here we're just redirecting that. My bad. It's important to see. So this is a cool shot. So these are two pictures again from that posterior portal. So here's showing the reduction of the capsule to our anchor following that first anchor fixation. We then use the 2.6 self-punching anchor just superior to that. We used the prior traction stitch to pass our repair suture. We then used the 45-degree suture passer here, and we'll pass the shuttling sutures once again, just similar to how we did before. This anchor also comes with a 1.7 millimeter suture tape that we'll use later to close down this defect.
also why I think some of these companies should come up with dual and try cannulas, because you're in such a tight area.
Here you can see we're shuttling the repair stitch. And you can see how the tissue reduces back to the humerus. Then we'd use the 1.7 millimeter suture tape to do a side-to-side repair of the capsular defect. And tie a knot on the outside of the capsule.
Like this 2.6 version of the tape. I would like to put one lower down at the angle. I'm using the angle guide, smaller.
You can
It's a novelist, that 2.6 has a novelist.
Yeah, that's what we have. Absolutely.
We did use that actually. At one point, the angle was not appropriate for the suture pass. We used the first pass for one of the passes.
First pass now a curve.
They have left and right.
Which is helpful. I love that device. Wait, stop using the Scorpion and use his,
No.
First pass, Scorpion, all the.
it's wonderful for shoulder stabilization.
This guy talking over here probably wrote the first paper when you were a fellow, right?
Yeah.
Hagels with Russ Warren.
Yeah.
1990,
89, 90.
89, yeah. Right there, Bernie and Russ. It's really like, it's pretty interesting. It's one of the first papers ever on, we did it open Hagel.
Yeah.
Repairs, kind of looked at all of them.
Was the paper for reverse and anterior or?
No, it was
Anterior.
We did the reverse and anterior. We had about 20 some 30 patients in that study. When they presented, they were interesting, and that's why I like fixing these early. They don't do that great at the end of the day. They don't, especially in a sport where their shoulder is pressing, internal rotation, flexion. Their job activities require their posterior stability. They just don't do that great. These Hagels, whether it's anterior or posterior, some of them can heal a la PCL style. I think they can do okay, just depending on what you're doing. What was interesting, the biggest presentation complaint with a Hagel though is not instability. You wrote on this in the 1990 was, and we found the same thing, is shoulder not working well and just kind of pain.
Yeah.
It's like, it just doesn't feel right. I can't do what I can't do. And then they come with you 2-3 months later and I can't get in a weight room. I can't play football. I can't do these other things. So I like fixing these early. The anatomy is beautiful. You did a beautiful job fixing that. Good case.
We got lucky on timing because he was like, came in, this is a transfer kid, actually to play for us last year. And he came in and he had this injury like, I don't know, week before he showed up in August or something. And, just kind of doing the math on it. I think we have just enough time to kind of get him to a point we can clear before the season. Yeah, but it was like, I literally never met the kid. It's like, hey, listen, so he's in surgery. And he wasn't really, he was receptive to it because this was a true dislocation event to the back, which you don't see as much. And you're right, after they have their first event, most of the time they just have pain. They don't really have recurrent instability. But this guy clearly had gone out the back with his reverse.
The other thing is about half we found didn't have label tears, which was,
Yes.
but you didn't have here.
But you can see
Might have had a
both.
small
You
crack
can
here.
see both too, right?
Yeah.
But sometimes maybe that's a
About
lucky sign.
50% with a quote unquote floating capsule, as we dubbed it.
Yeah.
Labrum plus capsule.
And that's trickier to fix too, obviously, 'cause you gotta do.
Yeah, and we ended up with more stiffness with those. We had more turn girth, internal rotation, and they still end up with pain because now they have girth. And you're like, oh, should I fix it in the first place? And you're like, I'm an idiot. I don't know why I did this.
So we had a conversation at Herodicus. I want to ask your opinion, Steve. We had a conversation at Herodicus about haggle. And there were a group of people that were very comfortable doing this, a group that said they wanted to do it open due to any neurovascular issues. So what are your thoughts? Is it patient dependent, and how do you think about it?
No, I think, so these are sometimes, especially the anterior ones, are really hard to access. This one really, he showed you, really went under, it way down inferiorly, which is I think where it becomes challenging. When I see these, most of the posterior ones I fix arthroscopically. Because I think you can get there and you can see very well, and I think it's fairly safe. The anterior ones, I've honestly never fixed an anterior haggle arthroscopically. I've always gone to doing those through an open incision. You can take down like the bottom part of the subscap. You can leave the top part even attached.
kind of open up a window, it's like staring you right in the face. And it's just a really, it's a nice way of fixing it, and I think much safer. So that's how I've done it. People certainly do them arthroscopic. I don't know what, if you guys have experience with that, but
Yeah,
I don't know, it just seems hard.
they were kind of done both. In our paper, it was literally on the sagittal oblique. If you had the orthogram, or I don't know if that was, or if it's a gram, but if it was 6 o'clock posterior or endoscopic, if there's anything that trended anteriorly, 637, 730, I'm just going to mini open, preserve the sisters, and it's right there. You can,
Yeah.
and
So
fix it,
years
repair
and
it.
years and years ago, when I was a resident fellow, we heard that posterior shoulder dislocations maybe comprise 3% of all dislocations. That's Rockwood. We see more of them now in football players, or more posterior limb. Do you know why?
Blocking technique.
Yeah, let's say that.
I was asking him.
Sorry, sorry. Sorry.
But they're blocking like this. When I was in high school, you had to have your hands in.
Like that was a rule at that point?
Oh, yeah.
Couldn't extend.
You couldn't do that.
You actually couldn't do this in college, I think, till almost 1988.
Yeah.
The pros started first, but you had to block here and you had to hit with this.
Okay.
Yeah, and it's,
You hit with this.
yeah, you did hit with that. Yeah, that was the big change.
With the leather helmet and whatnot, right?
But that one change made gave Bradley the ability to have all those.
Exactly.
Yeah.
He probably was involved.
I'm gonna call him. I talked to him the other day. I told him all you guys would be here. He said, and I'm gonna tell him, you should have piped in on this one, but you're right.
But
You knew that answer, though,
like
right?
reviews and chapters still quote like a very small number of posterior instability. That is not accurate.
It's not.
Posterior instability is really common.
I also think it's the weightlifting techniques too.
Absolutely.
We have a lot of strength coaches that do a lot of cleans. They do a lot of dumbbell pushes, and they do a lot of areas where basically you're creating a Kim lesion, right? You're at an angle coming down.
Sure.
Exactly, and we see that. On top of the fact that in 1985, the last time I saw it, like 1985, the average NFL lineman was like 275. And at least when I was in Wisconsin, we didn't play anybody under 330. At Miami, we're trying to find those guys.
We're doing a better job recognizing it. I think it's been there. It's seen us. I think we
Yeah,
missed it.
exactly.
That's probably
Past.
true.
It's an inherently unstable area. The capsule is 3x as strong back there. The labrum's 3x as strong. 3x as strong. It's not as good, and so it's an inherently unstable area if you have the associated stress on it.
Brett, what's your favorite test in clinic in terms of diagnosing? And this is not to pimp you. I'm really curious in terms of when you feel the shoulder, you're learning to feel the shoulder. I know it's the beginning of the year. What do you like to look at for posterior instability?
Yeah, so I think mainly pain, so getting pain with the kind of that directed, posterior directed force and with a little bit of adduction in the shoulder. I think that's been the most concerning for me for like posterior labral pathology or posterior injury.
So the two things I look for, and I think I started this because we have a pretty big baseball experience, but one is, we always lie people flat and also do it sitting up. I also lie them almost in a beach chair. Our beds can do that. Definitely do exactly what you said, right? Kind of a posterior load shift. I also will bring it up and they'll usually tell you, like you can bring it up and load posteriorly almost like a Kim test. And the other test, which has been described for many different things, is the circumduction adduction test. If you have true posterior instability and you put your hand there, you'll also oftentimes feel them kind of coming out, and you can feel, it's a game to me, where are they actually coming out and does that match? And on more subtle instability, especially, with our tennis players and volleyball players, that's sometimes helpful to get them in that position. In addition, getting an A-bear view on MRI is helpful because sometimes putting it in that position, although I'll tell you, somebody like this would have probably been way too uncomfortable in the MRI scanner to do that.
So do you do that pretty routinely then?
We try to do an abducted externally rotated or above the head. You're really not here in the scanner because it's too tight, but we try to do that at least with throwing athletes, volleyball players to really get the view. Although I could tell you that with a good radiologist Matt brought up the point of the hemogram versus an arthrogram. I've had this conversation with Andrews many times. He's always loved arthrograms, the elbow and the shoulder, but an acute injury like this, I'm pretty sure you don't need it. And oftentimes with a good radiologist and a good scan, our problem in Miami is the cost of hospital-based scans. I'm sure it's the same here, are very high. A lot of people will go to these scans. If you're below 1.5 Tesla, it can be a problem to see it, especially if they're not experienced to get the cuts. And so, that's varied on what you could do. But I like trying to match that physical exam, is my point, with the MRI.
You want to get that elbow up above the shoulder too.
Correct.
Because if you have it down and you're just driving it up into the acromion, you may get a fall, kind of going posterior superior, but it's really posterior.
It's actually posterior inferior, I find sometimes, like you go above 90 degrees a lot of times, you can see where that was.
Above the shoulder as you apply that posteriorly directed force.
You're pulling on the labrum right where the posterior inferior ligament is. So.
You can often feel roughness too.
Correct.
It slides on that word. What's next here?
You guys want another one, then we'll go, or how much
Sure.
time?
Yeah.
We got plenty.
This is better than the AOSSL.
MRI can miss it though. I mean, just understand it, even on a good 3 Tesla.
So you made a comment on hemogram there. So, with instability, you can do that. Our radiologists still like contrast even early. And I think with this injury, it's very, maybe with the labrum, not as much, but with this injury, I think having the orthopedic.
Did you do this graphic?
No, I don't.
This graphic? That's really cool.
He wanted to put
I think you just took it off TV. That's a great graphic.
It's from ESPN.
I say you bigger.
Oh, okay.
Big dad, I'm sure that dad.
So Dr. Tagliero is from Miami, and he's a double agent today.
There we go.
Every time we pick off Miami, I'm gonna make him wear a turnover chain on our side.
Pretty sweet.
I expected Lee to be wearing that this morning.
All right, so this case is actually a case from Dr. Diduch's service. So this is a 14-year-old female patient who presented to our clinic with right knee pain and a history of patellar instability. She presents with 2 frank dislocations earlier this year in greater than 10 subluxation events. She most recently injured her knee 8 days prior to presentation during a lacrosse game. She had anterior knee pain and an infusion. She was initially seen by a pediatric orthopedist in Roanoke, was given an immobilizer, had negative knee x-rays, and then presented to us for further follow-up. She's premenarchal, and she has no significant past medical or surgical history. Her physical examination demonstrated an effusion, patellar tenderness, apprehension, and her moving patellar apprehension test was positive up to 90 degrees. So for anyone in the room who may not be familiar with that particular test, so what you're doing is essentially, we're all familiar with measuring quadrants of mobility with the patella in full extension. And so if you bring the patella laterally in full extension and patients have apprehension, you'll say it's a positive apprehension test. What this test aims to do is you'll apply that lateral force and then slowly flex the knee up. And what you're trying to find is the point at which the patient no longer has apprehension and you're no longer able to translate that patella laterally to create that sensation. And Dr. Diduch taught me that earlier this year. I found, at least in a few months that I've been doing that test, that if there's an uninjured side that's uninvolved, usually around 30 degrees or so is when you find that 30 to 40 degrees. So 90 degrees, you can imagine, just how unstable this patella is for this girl to get her all the way up to that position and still have apprehension. She also had kind of a hyperlax female in general. So here's her preoperative x-rays. So this AP lateral sunrise view demonstrates her wide open growth plates, which is important for this case. And you can get a sense of just how high her patella is riding and how long the patella tendon is here as well. So we have some MRI. I'll take you through some cuts, and then I have some cuts that I've saved, sort of key cuts here. But as we come through the axials, I don't like how it's over there. I might just let it play. As we come through the axials, you can see that her patella is riding laterally. She has a little bit of a lateral vector of pull of her extensor mechanism, but at least to the gross eye, her TTG doesn't appear to be huge. You can see that she has a little bit of trochlea dysplasia as well, kind of a type B trochlea, and you can see a bone bruise here on the femoral condyle consistent with her patellar dislocation event that brought her to see us. If we look at her sagittal imaging, this one goes a little faster. Maybe I can control it. No, so if you look at her sagittal imaging, there's no chondral injuries, there's no meniscal injuries, no ligamentous injuries to the ACL or PCL. And I'll bring it back through here and I'll try to stop it at a point where you can really appreciate how high her patella is sitting. So this cut here, you can really appreciate how high our patella sits, how low the patellar neck you have. And then I'll take us to this cut that I've saved. So on the left here is her TTTP, which measured about 10 millimeters. The central image demonstrates her PTLTR, which is 11. And then the rightmost image demonstrates her Catan de Champs, which comes out to be about 1.6. And you can also see that she's kind of at that critical point of patellar-trochlear overlap at or below 20%. This is a 14-year-old girl, skeletally mature, patella alta, recurrent patellar instability. Some key data to consider, as I mentioned, skeletally mature, MPFL deficient, significant alta at 1.6, patellar-trochlear index under 20%, and she does have this lateral vector of pull. We're somewhat limited in our options because of her skeletal maturity. So, if this was somebody who's older, you could consider tibial glossiotomy, correct the alta, correct the lateral vector of pull. You could consider, I didn't measure her supratrochlear spur here. She's a small one. If it's large enough, you could consider whether or not there's something to do with the trochlea as well in terms of reshaping that anatomy. Those are out for this patient. And so taking all of this into account and the fact that she's had so many recurrent instability events, we didn't feel that isolated MPFL or non-operative management was really going to be a solid option for her. So we plan to proceed with an open MPFL reconstruction with a gracilis allograft and a patellar tendon primary shortening. We measured that to be 13 millimeters, and I'll discuss that shortly, as well as a diagnostic arthroscopy. The idea of the allograft was that this gal's rather petite, and so her own autograft tissue gracilis we suspected would not be large enough for her, essentially. So here's some preoperative planning for this case. So you can look at the sagittal cut here. Preoperative Catan de Champs is 1.6. We measured that if we shortened her by 13 millimeters, that would get her to our target goal of a CDI ratio of 1.1. So there's a very nice technique by Dr. Andrish. This is kind of an update to his prior originally published technique. So this one is published in OJSM in October of 2020. And looking back at the original technique in this one, the main update is that this technique uses an additional level of sutures to imbricate this flap. Can you see my pointer? Yes, imbricate this flap of patellar tendon back here. So I'm going to take us through this with some intraoperative photos, but it can be a little confusing. So I'm going to kind of explain a little bit up front here. So the distance here, A, is the amount of the patellar tendon that you aim to shorten. So whatever you measured. So for us, we measured 13 millimeters. So that's A. From A to B here is 1/2 that distance. So for our 13 millimeter correction, A to B, the B line is 6.5 millimeters from the top here. And then you'll see that there's a line that's then drawn after you elevate part of the tendon here, and that line is also 6.5 millimeters from the top of your correction. In doing so, that allows you to close that area down and create this flap of excess tendon in the back that's the same length as your shortening. As I go through the intraoperative photos of this. So here's the intraoperative photo. You can see that we've already drilled for our patellar tunnel. So Dr. Diduch's preferred technique for MPFL reconstruction is a two-tiered graft through short oblique tunnels in the patella that exit about 1/3 to 1/4 of the way through superiorly. So we've drilled that already. We've skeletonized the peritoneum here and retracted that. And then it's important to identify medial lateral borders of the tendon and to have a good passageway underneath. So that's what our elevator is demonstrating here. These are going to be passing sutures deep to the tendon throughout this entire procedure. So now we'll measure. So you can see here, we've measured our imbrication of 13 millimeters here. This is our planned shortening distance. This is the 6.5 millimeters. So here's our 13, that's A. Here's our 6.5. This is from A to B, which becomes important as we start to pass these sutures. Here we're starting to elevate this tissue. So you take your 15 blade and cut transversely across the tendon, which is a little bit stressful. And your goal is to get 50% thickness here and then start to elevate a flap. Okay, and so as you do that, you can see just how thin this is. The elevator back there is essentially translucent. You can see the elevator through the back of this tissue. But here we're elevating that flap. And so now we've elevated our flap, our 13 millimeters. We've drawn our second line, which is equidistant from both lines here. So 6.5 millimeters of distance here. And now we'll begin to pass our sutures, which are going to allow us to shorten our tendon. So here we're beginning to pass our sutures in step 3. So these sutures come from the top of line B, deep to the tendon, and then they exit here at the line in the middle of our shortening. And I'll zoom in here so you can see after we pass these sutures, these are passing a Mason Allen configuration along this line, which allows it to lock and not pull longitudinally through the fibers. And then you get these 8 suture limbs from 4 sutures that exit here at line B. And these are going to be used to imbricate the posterior aspect of this tendon. We then pass and those are absorbable. Our non-absorbable sutures through our main shortening line. So here's that 13 millimeter measurement is here. we pass our non-absorbable to our orthocords through the top line here, in through the area where we've elevated, and then they exit at the distal end here. And again, Mason Allen configuration along the bottom to prevent any cut through. Now, as you go from step 4, which is here, after passing all the sutures, to step 5, which is to tie down your sutures here, it's important to note a few things. So the first thing you tie down are your non-absorbable orthocords. That shortens your distance. So here's our 13 millimeters. We tie that down, and that creates our patella shortening. As you're doing that, it's important to have your assistant apply a distal force to the patella. So they're pushing down on the patella here to help reduce it into place so that you're not putting too much strain across the sutures as you're tying them, and you're not offering the opportunity for those to pull through the tendon. Once those are tied, you can then go ahead and tie the absorbable sutures, the O vinyls that you passed up top. And in so doing, you pull this flap here up along the bottom, and you essentially create a triple thickness. So you can see kind of how thick this tendon is now in the area where we've worked. So we've already completed our shortening. We've tied down our posterior flap, and we just have one step left, which is that anterior flap that we elevated. We're going to tie those sutures down, which you can see here, and that's step 7 here. So you're just tying those down with absorbables to the patellar tendon distally. So now we've shortened her by 13 millimeters, and we're very happy with the security of these sutures. We've ranged the knee up to about 90 intraoperatively, no gapping, no issues. So here's the intraoperative film. So this is us when we're going to do our MTFL. And so I took this forward, measured. You can see that we got our katana shafts down to 1.1, which is what we hoped for. I think it's important to discuss a little bit about the MPFL as well. So for the skeletally immature patient, you can see Dr. Diduch here, we're obtaining our point to begin our femoral socket. And it looks initially, when you look at the spinal x-ray, you say, oh, that's right in the middle of the physis. But if you think about the physis on a coronal view, it curves up at the medial and lateral ends. So we know that this point is distal to the physis. And then the other considerations when you're drilling this socket and you're aiming this pin is you want to find a way to be deep enough to the trochlea where you feel safe passing your reamer to create your socket, but also outside of it. So getting a notch view as well during the procedure after you pass this pin yourself out of trouble. So looking at a little bit of literature regarding the patellar tendon inversion technique from Dr. Andrus. So this case series that he published in RJ7 in 2020 was 27 specific patients. And it was over a 5-year span with minimum 2-year follow-up, 32 knees. So they measured insult savati, Blackburn fetal, and katana shafts preoperatively at 3 weeks post-op and at 2 years post-op. And they found that on average, their patients were shortening their tendons by 1 centimeter, 13 millimeters for our case. And their corrections at 3 weeks post-op were maintained at the 2-year post-operative period. So intraoperatively, we're very happy with that correction. When we get her back and see that first film, if everything looks as it did, then we can feel pretty confident that she's going to go on to do well. Interestingly, Dr. Andrus commented on in this paper that the patients in which he was doing this tended to have an abnormally long patellar tendon. So their patellar tendon length was around 61 millimeters or so. So certainly some underlying anatomy differences in the patients who are. Thanks.
Good job.
That was a really nice presentation and description of a complicated procedure. And Jack is very, very thoughtful. He has a lot of experience from the pediatric side because he's primarily a pediatric orthopedic surgeon, but has a special interest in the patellar. So when that originally came out, the original technique, there were only 10 or 12 patients. And I looked at it, and I thought about it, and I thought, it seems really complicated. And but I know Jack, trust Jack. And then later, it's been described in adults as well. It's a really tough case because that's the triple whammy: skeletally immature, malalignments, maltracking, and recurrent instability. I mean, it would be more of a slam dunk if she were skeletally mature. I don't think you need a trochleoplasty. You can do a tuberosity, intermedial discalization, or medial discalization and have a cure, and then throw in an MPFO reconstruction as well. I think, and you pointed this out, you showed the order of the case. I think it's really important that you change your patellar height first, whether you're doing an osteotomy or doing this plication shortening, because that changes the tension, knee flexion angle on your MPFO reconstruction. And The other thing that's really interesting, and we're just trying to figure this out right now. Actually, David and I are doing some work on this. Depending on how you do your MPFL reconstruction, you actually change patellar height. So for example, his approach, and you mentioned this, the double bundle approach. When we looked at his cases, you decrease CDI by 0.08 on average. Whereas I use a single bundle approach and it doesn't change CDI at all. So that also has to go into your calculation. If you don't want to over lengthen or over shorten, that's even worse. And I think the last point is make sure you tell these patients they're very likely to have angina pain. Even if you solve their instability problem, the first conversation you have from the very beginning, you find out, do they have rest pain in addition to instability pain? And you tell their parents, you can address and solve and have a high likelihood, high expectation of improvement for the instability. They need to expect that they'll still have anterior pain post-operative.
Dave, did you do a medial retinacular repair? Did it look like?
No, just the MPFL reconstruction.
It looked like the retinaculum on the coronal view. I mean, coronal view, our axial view looked like it was off the beta side.
Yeah, no more than just, creating a window for passing the MPFL than just suturing it back. So no implication there at all.
Have you had any experience using the hamstring allograft that you just shuttle around the adductor tendon? So you have so much collagen, and it obviates having to make a drug. If you're doing it in an adult,
That's
having to
absolutely
make a
a good option with a growing kid.
Yeah.
And you avoid any tunnels whatsoever. But I think with careful attention and fluoro, you can get it right. And
This
it's
is
going to be
a
more
awesome
accurate to
case.
put it at Shuttle's point than around the adductor. That's the second best, I think. So he didn't show the AP view, but we go back and forth lateral AP, and you can get your starting point distal, and you can aim across and distal in the epiphysis and stay clear of the growth plate, pull it through like you normally do, fix with an interference screw like you normally do. So some people use anchors, but I can still use the conventional way. I just downsize the size of the tunnel. I think
I
that's just
transitioned to the swinging the tendon around the adductor. It was such a pain getting that X-ray, and I'd flail away for about 10 or 15 minutes, and I'd say, "Okay, that's it." And then you see the post-op X-ray. Say, "Now is that it or not?"
Dave, a question from the chat. How do you code for this? Like as far as like CPT?
It's a great question because there's no code.
Not exactly this.
We code it as a patella tendon repair.
Did you really?
We'll see what happens. We shortened it.
You did repair the patellar tendon? I mean, that's
the best we had. Yeah.
With a 2-2 modifier.
Yeah.
Yeah, it's a tough case.
I did the whole case.
I took care of someone a few years ago.
How do you walk you through it?
Yeah. She'd had an MPFL reconstruction, skeleton immature, and ended up needing distal femoral osteotomy. She actually worked out fine, at the end of the day, but it was very significant deformity at the femur side to side.
That's encouraging.
Yeah. But they hadn't used fluoro. I mean, there was, when you go back and look at the case, there's some lessons learned very nicely that you showed. That you have enough distance there. If you pick the right anchor, you don't need a 7 or 8 millimeter screw. You need something small. You just need enough.
Tom, did you?
What are you telling these young people about their long-term health of that patellofemoral joint? And you mentioned the short term, but what about the long term?
I think it should be very good. Should be better than if we didn't do this. Well, I can tell you this. The alternative is to wait for them to finish growth. And I've treated a lot of people both ways. And I've seen catastrophic injuries just the next time, and the next time's coming.
Mm-hmm.
And catastrophic, huge chondral pieces sheared off, letting them finish growth. As their body mass grows, the consequences of a dislocation are more pronounced. And so now I'm more, with recurrent instability, they're going to keep doing it. I'll counsel them. We should fix this now. I think that's the way to go, like the ACL.
Adam, what's the indication for lateral release and patellar instability? Lateral release.
Yeah, thank you. Thanks, Dr. Bach. So what we've done is gone to lateral retinacular lengthening. And so the decision point for that has been intraoperative. And so at the end of irreversible reconstruction or any concomitant osseous work, essentially taking the patella, feeling how.
So why should you or should you not do an isolate? You say, okay, I want to minimize, surgical trauma to this young person. Why should you or should you not do a lateral release just for patellar instability?
I think we've learned from the papers published in the past that isolated lateral release does not result in favorable
And what
outcomes.
happens?
You have
If you do
medial,
a lateral release, what happens?
you can end up with medial patellar instability.
Well, excessive, yes. But if you do a lateral release, it increases the Q angle.
Isolated lateral releases patients.
Yeah,
do.
Terribly.
But I mean,
We talk about that all the
I've been
time.
around a lot of,
How many lateral releases
lot
have you
of
done?
that lateral release was used for just about everything related to the patella. And, the only indication is excessive lateral patellar tilt. That will work well. But you don't take the release up to above the proximal patella. Used to talk about doing 6 or 8 centimeters of the lateral release.
You guys have a case?
You did, I mean, in the early 2000s, you did less.
I did a total of 45 in my career, of which
You did all work until,
yeah.
it's not a good surgery.
Can I make one other point? So, we make a big deal about TTG measurements, and we're looking at the Q angle in extension. But I find if you flex a knee, just have the patient sitting at the end of the table, and you start to get a sense of how much external rotation you have of the tibia, there's a dramatic, very, very amount of variation. And you can get people that have like 60 degrees of external tibial torsion. And when you think of patellar instability, you plant your foot, you're doing that. Well, look what's happening dynamically there. So that impacted in adults some of the decisions I made surgically.
That was a very athletic move. I'm glad you're not playing for UVA today, although you have their. You got him a green sweater so he could be on our side. That gets year
Even
after
I used to be able to dunk a basketball, but now I trip over white lines.
What's that?
Pretty good for me.
Right. So we kind of did ourselves football faces, so we got to football.
Oh. Goes posterolateral.
Practice. So essentially, during practice, their 18-year-old right back injured his leg. Had a hypertension, tackle, pain and instability. Physical examination, infusion, positive. He also opened up with various stress to 3 degrees. Luckily, he was neurovascular intact, including the cranial. These are X-rays here. Here you can see a small avulsion here. I'm just going to run through the MRI here again. Better this time. These are some representative X-rays. MRIs. So essentially, had a right ACL tear, injury to his posterior lateral corner, had an avulsion of the insertion of his LCL and bicephalmoid tendon. His popliteal ligament was torn, but luckily his popliteus tendon was. he opened up about 10 degrees. A little more, it was a little bit hard to do, like we couldn't do it prone because he was too uncomfortable when we saw him initially. So kind of did it more, like I guess kind of a doll test when he was under anesthesia, kind of the knee flex. So not like a real. So plan was for arthroscopic ACL reconstruction with BTV autograft, and the plan for LCL bicep femoris a repair versus reconstruction. Again, it was an avulsion injury. We were going to assess the tissue quality intraoperatively and see if the amount of retraction, and also under consideration or the order of fixation of the structures of the posterolateral corner with the ACL. Another consideration, although his peroneal nerve was intact, it's going to be in the field, so just have to keep that in mind. This is just a study. Yeah.
Dr. Miller asked you a really important question. How do you examine? If you look at that video, you see almost a hyperextension nervous mechanism. How do you examine a knee for posterolateral laxity?
Yeah, so ideally you want to have them prone, and then essentially you test, you start to rotate their tibia, do it at 30 degrees and 90 degrees to assess the degree.
So if you were looking for an isolated posterolateral injury, is the external rotation going to be greater at say 30 degrees or greater at between 70 and 90 degrees?
For an isolated one?
Yeah.
I don't know if it's 30 degrees, usually it's just isolated positive if
30. And can you have a posterolateral injury with an intact lateral collateral ligament? Yes or no?
I don't know if it's
The answer is yes.
But then but his point is then you would blow out the popliteus.
Yeah.
Right, so he's giving you an anatomy question. Do you guys understand that? So what Dr. Bach is saying is, so what Dr. Miller said, so what you can do in these situations, and we evaluate that on the table too, which is the best exams for me are immediately when they do this on the field, if you can, before they start even recognizing the pain, and then also obviously once they're asleep. But what Dr. Bach is asking you is, and it goes back to some of the original HSS LeBrod stuff, and quite frankly, really Mark Miller stuff, that when you're looking at that, you can have a straight lateral injury, right? Once you start injuring the biceps, you definitely have to start thinking, and sometimes in basketball you'll have that or a direct blow. But what he's asking specifically that it missed was you could have the popliteus tendon out, right? So the popliteus tendon is still a little bit of a lighthouse in this injury. And that's an important thing to think about.
The other way to look at it is stress radiographs, like opening top of rotation. So 2.1, 2.5 millimeters, generally side to side difference, certainly been LCL. Before 4.5 millimeters, you're starting to think about LCL popliteus. It's not 100%. And yeah, NPFL for sure. So 4 main structures on the lateral side that we're concerned about, which we described at least three here. The only wild card here is once the biceps is out of lead, it does add, the exam gets a little more challenging because of rotatory issues and even some lateral stability issues dynamically.
Well, the one thing that, and Mark, if I'm giving you credit incorrectly, still take it. But for some reason, I remember you speaking about this, I think at Herodicus one time against something that Chris Horner was saying. But, the capsule itself also should be considered as a stabilizing force. I usually give you credit for saying that. And I think it's important to look at that as well. But these are all really important.
You mentioned the order of tensioning. That was Gilbert's study when he was at Vail. He's from Norway. Did with us. We did on the robot together. It's a pretty interesting study. But this was a bicruciate study. But in general, we sort of had fix the posterior lateral, do all the drilling, do everything, and then fix distally last. Is sort of been our approach. In Vail, get the bicruciates done or the cruciate done, get a posterior lateral for the final. Just showed a little bit more appropriate way to kind of retension the structures.
But yeah, essentially, the CRD, it is a cadaver study that they recommended tension in the PCL, ACL, and then the posterior left corner. Found at the attention, the ACL.
This is a robust site. It was amazing how much it constrained if you did these in different orders. It was very interesting. If you did the posterior lateral first, you set the tension of the tibia pretty anterior, and you couldn't get the PCL. You were never given the PCL a good advantage.
Yes, you have to restore the central axis.
Correct.
And sometimes every once in a while you have one that is so crazy laxity that it dislocates during the case, and you need to use fluoro to make sure you fix the PCL and the proper amount of tibial step off. It can be really profoundly difficult unless you sometimes use the fluoro to fix that first, and you go from something profoundly unstable to manageable.
Yeah, in general, we've kind of just taken the posterior lateral fat last with
Right.
everything at the end of the day. Get the center done. Even if you just have one ligament, you're probably okay because at least you have one there and you're not. Cool. So what you guys do for this?
Yes, essentially, I kind of describe. So essentially, the ACL reconstruction. Currently, whatever was seen in the field, we decompressed it with a protected front case, just also protected from the post-operative swelling. And then the LCL and biceps tendon quality was actually still very good. So each were repaired down with an anchor, and we kind of like we fixed the ACL first approximately, and wait until the end to do the distal fixation once we're ready with the lateral side as well. For pictures, we have some arthroscopic pictures pictures of the open part. Now, approximately 2 months from injury, doing very well. He has full knee range of motion, calculated without aids, which to me was very surprising. I guess I'm trained in Morgan trauma centers and seeing patients with more than one ligament injuries, usually 2 months after doing that well. But again, he's an athlete and they get excellent post-operative care.
One interesting thing, I've had 3 of these in running backs. The first 2 have come back. One of them's in the he hurt it last year in October. He's now trying out for NFL teams, kind of during this part of somebody else will have to get hurt. But the point is, they've all looked the same. The running back last year, we're playing Carolina. He's running to the right. There's an opening. He cuts in between the safeties. And as he's planted, a cornerback comes from the side, and it's the same kind of deal. I will say this, though. They all seem to have a little varus when you look at them on the other side as well. And then when they go into that hyper situation, it causes this. And they just avulse. Getting back to your point earlier, this is one I would do it all at once. I still think that the central, Mark called it the central axis, I call it the central pivots, but whatever helps in stability of these. The other thing is, I'm not convinced that these people have anything genetically similar to me. His tendon graft took 3 saws. Okay, so his bone is cement, and so my feeling was really get the anatomy back to its place. The other thing that wasn't mentioned is when you're back there, whether it's capsule, the PFL is really, we were talking about too, get kind of together. You can suture that up too while we're doing the biceps tendon. But most importantly for me is get it in the right place, make sure they don't do too much early, and then bring them along slowly. I'm still very hesitant to jump them back in. I mean, this is to me a UCL in the elbow. We say it's 12 months, but it's probably 18. Even when they come back, I think it's going to be a challenge.
Well, thank you for calling it the LCL. I don't like the FCL. I don't like that term. Ron loves that term, but I don't like it.
I don't like it either. I like LCL. The other thing we've seen in these is tib fib instability, and so we do a really nice side to side exam. Flexion, because that capsule is very close to the tib fib, that anterior capsule, the amount of energy, because they hit the fibula, especially with the biceps femoris injury. It's a high associated injury to have tib fib instability. So it's another thing to look at. That's a good case. The literature, these are the ones I think you can get away with repair. But the literature in a chronic LCL for repair is not very good. I think the repairs here, we have nice tissue, proximally avulsed. that small biceps avulsion, which are very challenging to take care of, by the way. These are, I think you can get a really good result with the LCL when you have it, because they haven't had that chronic center bungee cord stretch that just doesn't come back.
The tissue ball is not that good. Sometimes you try to sew it and it's pulled, it's suture going through.
Yeah.
But we do one more case really quickly. This case, I think is.
Hey, David, Rob Schutterbeck, I got a quick question for you. I had a similar injury like this, bicep and LCL pulled off, ACL, lateral meniscus, but his peroneal nerve was completely out, foot drop, numbness. Would that change your guys' direction of treatment? My thoughts is what I did is I just stabilized his LCL and fixed the popliteal tendon, and then my hand person came in and wrapped the nerve. It was not transected, it's just a little stretch. But what are your thought processes on dealing with if the peroneal nerve is out? Would that change what you do?
Yeah, I think that's a great question, and quite frankly, almost exactly what you did. Usually you can see it matches the MRI. You have edema in the nerve, sometimes discoloration right at the level of injury. What we've thought is to also make sure both, and we actually did one of these recently, just what you said, with a hand surgeon to wrap it, but to make sure that both distally as well as proximally, they have room. Sometimes people will release it distally. We've had this conversation, proximally, and not think about releasing the nerve distally. And then you wind up still having some tension on it. I think the most important thing you can do in that situation, quite frankly, is to have a discussion with them. We have a wide receiver who was a walk-on and for some reason probably overstated his athletic ability. He had this. He heard that Dan Cooper did one of these in Dallas and had a kid playing with an AFO. I think that that's a reality check too, right? If you run a 4.6, you lose 10% of your speed, and you're running a 4.8 at wide receiver, at least in our conference, you're not playing. So I think a large part of that would have been my discussion, and I involved the family and just tell them I want them to have a healthy knee for life and make no promises when the nerve might come back. I will tell you that our neurosurgeons aggressively they'll wait obviously in this situation, but if it's not coming back, they'll do all kinds of fancy procedures and grafts, and they have horrendous results long-term in athletes. So if the nerve's out, I would do exactly what you did and wait it out a bit. Now, one question I have though for Matt is there any role for antifibrotic agents, which you guys know we're going to now, I guess, with Tom, work with Johnny? Would you consider that in this situation?
Yeah, I mean, like you said, I'd throw everything at it. And just like you approach is I go in a full decompression. My perineal nerve treatment is 100% the same every single time for this. Release proximal, release distally, release just so you see the muscle fibers, tibant around the fibula, so that you do decompress it. And I have my hand surgeons. I don't let my neurosurgeons come near this because they don't know what they don't know what they're doing with this. Honestly, you need a peripheral nerve surgeon. Their hand surgeons are so much better at dealing with this. But yeah, you got to lay a lot of crepe. I mean, if you look at that initial being out, even if it's in continuity, you probably have a 30 to 50% chance of recovery of that nerve. It's pretty sobering. It's very sobering data, unfortunately.
I did not end up doing the ACL because I just wanted to. I don't want to. I was concerned about putting in full extension and putting tension on the nerve in hopes that it potentially will return. I just want to get the lateral side stabilized and get him, moving. My hand surgeon was a little more aggressive than I probably would have been, but anyway. So now that just happened a week or two ago. So we'll see what happens.
Right. We put them on reasonably high dose vitamin C. Give them some warnings. From the fibrosis point, doxycycline, fisetin, losartan, 12.5 milligrams twice a day, and then some other multivitamin, nutraceutical stuff. We kind of throw everything at this. I don't know if it helps, but
cool. I want to run through this case because I think it's good for everybody on the outside, especially. This is a real eye opener. So quickly, and then we'll take a tour, guys. Yeah.
All right, so this is a 39-year-old right-hand dominant male. He's had left shoulder pain. He had on and off left shoulder pain until recently. So he He had a steroid injection done at an outside clinic on May 19th, and then on May 30th, he felt a pop while lifting a cooler into his truck. He's had pain and weakness of the left shoulder since then. He's been seen by multiple providers and actually saw Dr. Diduch in clinic as a third opinion. Relatively healthy otherwise. He is a smoker, however. So his exam, these are the pertinent exam findings. His external rotation was with active external rotation was 20 degrees, passive was 60. And then his strength was diminished on the left side as well, 3 out of 5 external rotation, 4 out of 5 supraspinatus. His radiographs were remarkable. Here are just a couple of still shots from his MRI showing an musculotendinous tear of the infraspinatus. We think this is likely secondary to the steroid injection.
Right in the tendon.
So the question is what to do. He's now 4 or 5 months out from the initial pop.
So again, the timeline to the injection, and then he had the injury with the cooler.
Yeah, the injection was about 2 weeks before the cooler injury. And this was about 3 or 4 months before presentation, I believe.
Was it a Yeti or an
That's a good question. It was a styrofoam cooler.
Yeah. So the plan is to do a right shoulder diagnostic arthroscopy, debridement, and then evaluate the rotator cuff.
I think you have to be careful about causation here. You know, we always worry about steroid and one injection. You know, it's hard to say. You know, you gotta be really careful. I've had to defend one of our colleagues from multiple steroid injections without quote unquote consent of rupture and talking about it. There's some case law out there having reviewed it. Fortunately, our colleague was vindicated in the whole thing, but it was very stressful and it was kind of ignored and went on to fatty atrophy and a reverse shoulder and all kinds of other things. So we have to be careful about causation, I think, but it's, you know, you look at it, you're like, certainly.
Yeah,
I mean, I
I
don't
don't
know
know,
what you,
occasionally it just opens your eyes.
Yeah.
This could happen potentially.
yeah,
I bet it happens more than we think, but honestly,
Yeah.
I do worry about it.
yeah.
I wonder if we ever get to a point where injection without some sort of imaging guidance becomes something that's considered archaic, you know?
Yeah,
And I understand, I mean, these subacromial space injections, we still do all the time, but
yeah.
just documenting where you put it, you know?
Yes, sir.
Quick comment. For those who are interested, our fellow from last year did his systematic review meta-analysis of subacromial patients with subacromial impingement and comparing corticosteroids to anti-inflammatories. Please familiar with it. It's actually up for the AMSSM Research Award this year, and he showed that the non-steroidals, I think it was ketorolac, I can't remember, were as effective as corticosteroids for subacromial impingement.
I like it. European like it.
Ketorolac though, right?
Yeah.
So big guns.
Big guns, yeah.
That's good though.
Yeah, I mean, it was
a systematic review. It's your series or is it a systematic review?
No, it's a systematic review meta-analysis, yeah. Yeah. There actually are 8 RCTs out there, believe it or not. I was shocked when he came to
Favoring anti-inflammatory for the most part.
Yeah.
It doesn't seem like that clinically, honestly.
I would agree, Steve, but the data's there.
No, I understand. Yeah.
And, the number crunchers made it look real good, so.
For a diagnosis that many people refute exists.
Yeah.
So just quickly, these are the intraoperative photos. Within the glenohumeral joint, there was no evidence of pathology. There's cuff, posterior cuff, all intact. Here's the subacromial space. Now we're looking posteriorly. That's the tissue that was eventually found. It was difficult to find in the subacromial space. And here's a video kind of demonstrating that a little better.
So it's like an L tear type of thing?
The L tear of the musculotendinous junction of the infraspinatus. You can see the supraspinatus muscle belly there.
Yeah.
The tendon
Right, the muscle
all the
tendon
way
junction.
coming distal. And then Dr. Diduch will grab.
Yes. You get a few millimeters of white stuff.
What's that?
Couple millimeters there. Fix that.
It's good. Did you find any like residue or whatever from an injection, nothing like that?
So do you think the tendon was inadvertently injected?
In this room, I do.
So we used, 3 ortho board, sutures starting in the, at the ankle, and then working our way distal.
So no anchor side to side stitches on the
Side to side sutures.
Long way from the bone.
Yeah, no, I mean, it looks like you have very good tendon repair tools.
3 or 4.
It was 4, correct.
That's a very rare injury. What's interesting is that's where all the scope portals are, where iatro injury is done all the time. It's right in line with the glenoid face.
Also, any type of dermal graft for this type of thing, just to kind of reinforce it a little bit.
Certainly could have, absolutely. Yeah.
See, I love that, but I always like, where do you attach it? On the
No, you're
muscle?
stitching
You
it
know
to
what
muscle,
I
right?
mean? Yeah, it's like, I don't know, does it float off and you need to scope it again and take it out? And I've had plenty of those that have been fibrotic or inflammation of the initial patch that's been advertised. We've got a lot of issues with that, one of those patches.
Brad, what will your post-op be?
So I would avoid any active external rotation, preferably get them in that external rotation.
Well,
Did you guys do that in the air brace?
We did not do the front, we just did the regular one. Thought about it, but
Probably with a muscle, you probably.
yeah, it was, yeah.
Would you approach this differently if he didn't have that strength deficit on initial exam?
Yes, probably would have treated him non-op, but he'd already failed that. By the time he got nails for the doctor, he was pretty, he was profoundly weak there. He had no response.
Any early returns on how he's doing, or it's pretty soon?
I bet that'll heal well. I bet that'll be just fine. I think it will. Yeah, I think he will. If it's issue up. Yeah, I think you know, there's just enough there. That's it's very, very good. It is. First time I've seen it. Type 2 infra. Yeah.
So one thing on that too, if you get it too far gone and there's a lot of atrophy, et cetera, that's actually a great circumstance for a lower trapezius tendon transfer. Like that's the one where I think that's a really good option.
He's got a few.
No arthritis, front of the cuffs.
No,
good,
my
anterior
anterior
cuffs
cuff,
good.
yeah, absolutely. That's awesome. Did you pull off that? Great case, everyone. Thank you.
Thanks to everyone. Thanks.
Yeah, thank you.
Yeah, welcome to, something to do.
Thank you, guys. Yeah, can we get a quick?
I was gonna have.
He's like a king of the hotel. Cool. Big multi-rig. Osteotomies.
It makes the virtual audience. What's that? Virtual audience.
Yeah. Can we put them on the background here on the screen and go really high tech? How you been, my friend? You do this? Airstrike?
You guys all come in.
Winston, thanks for inviting us. This is great. Thank you.
Thanks, Gordon. Thanks, Gordon. Good to hear you.
Hope to see you.
Okay.
Well.
Get a big group picture of everybody up here.
Oh, that'd be good. Or you just start shooting pictures and I promise it's fun.
The graphic in the background.
That's good.
Oh, yeah, I appreciate that.
Tom, come on, Adam, come on. Andy, come on.
Yeah. That history is one of those